Hi to everyone. I am Dr. Rana Pratap Maurya from Department of Orthodontics, School of Dental Sciences, Babu Banasidas University. Today I will discuss on the lectures on theory of growth. The growth of the craniofacial structure is a very complex process. So to understand it, we must know the theories and concepts of growth. So there are various theories and concepts are given by various authors like remodeling theory of growth, genetic theory, social dominance theory, cartilaginous theory, and functional matrix theory. These are theories to explain the growth, and various concepts are von Limburg's multifactorial theory, in-law G principles of growth, and in-law counterpart principles, neurotrophism, and service system. These are the concepts to understand the theory of growth. The first remodeling theory of cartilaginous growth, it was given by Brass in 1930s. This was the first general theory of craniofacial growth. According to him, all of the craniofacial skeletal growth occurs exclusively by bone remodeling. The bone remodeling is selective addition and resorption of bone at its surface. So sutures and cartilage of craniofacial skeleton, they have little or no role. Main role is remodeling. The second theory was genetic theory given by Aaron Brody in 1940, according to whom the entire growth process is under the influence of genetic control and it is pre-programmed. First, genetic controls it determines the certain initial features of growth, and then secondly, the local feedback and inner communication mechanism between cells and tissue it determines the uh, final structures. However, the mechanism of action of genetic unit and the mechanism by which traits are transmitted, it were not understood until recently. But nowadays, these are understand the various traits which are transmitted from one generation to the another. Next theory, the sutural dominance theory, given by Weinman and Seeker in 1952. According to him, the craniofacial growth occurs at sutures with proliferation of connective tissue and then it is replaced by the bone. Means first connective tissue grow, then replaced by the bone. So all bone forming elements are growth center like cartilage, suture and various. So these growth centers are primarily under the control of heredity, means based on the genetic control of growth. These are the various sutures like frontomagular suture, zygomatic suture, zygomatocomagular sutures, and pterygopalatine suture. These sutures play a role in growth of facial structures. So some points which were the favorable for this theory was suture between two facial bones when transplanted to another location, the tissue does not continue to grow. Means if sutures have a potential to grow, then it should be grow when transplanted to another location. But it was not found. So this point is unfavorable to this theory. Microcephaly means if the cranial sutures are primary growth centers, this condition can be not explained. In microcephaly, the skull size is less. So, if sutures play primary roles, then the skull should be growth, but it was not found. Same in cleft palate patient, grow continue even though in absence of sutures. Means if in cleft lip palate, if sutures is primary growth centers, then in cleft lip palate where the sutures are absent, then there should be not growth of palate, but it was found. So these points was unfavorable for the sutural dominance theory. Like here, this is microcephaly. Here the size of skull is small, and this is normal head size. So Here, if suture play primary role, means it will grow normally like normal head. Here, this is patients of cleft palate patients. If cleft palate, in cleft palate there is absence of suture. In spite of absence of suture, the palate grows. So these are the unfavorable for suture growth. Next theory is cartilaginous theory given by James Scott. It was proposed that nasal septal theory as a single and united theory of craniofacial growth. He viewed that the cartilaginous sites throughout the skulls act as a primary centers of growth. According to James Scott, intrinsic growth controlling factors are present in cartilage and periosteum, with sutures being secondary. So nasal septal cartilage is the pacemaker of growth of entire nasomegally complex and moves maxilla downward and forward. So mandibular condyle having cartilage at its end allow downward and forward growth of the mandible. So in case of maxilla, the nasomegaly complex, and in case of the mandible, the head of the condyle. So then they concluded that the various craniofacial regions, they are dependent primarily on the cartilage and secondly on the sutures. So there he explained his theory with following examples, like mandible. In mandible, the condylar cartilage are growth centers for the growth of mandible. In calvaria, that is cranial base and wall, the syncondosis, which is found at the base of the skull, is the primary cartilage for the calvarial growth. And sutures of cranial vault are the secondary. Means in craniofacial growth, the syncondosis, which is cartilage, is primary cause. Whereas in cranial wall, sutures are secondary. And in mid-face, the nasal septal cartilage is responsible for the mid-face growth. So points justifying Scott's theory was that when transplantation of nasal septal cartilage and epiphyseal cartilage of long bones show a significant growth. And many bones are formed by the endochondral bone formation. And if injuries to nasal septum in children results in a deficient growth of the mandible. And also the removal of nasal septal cartilage in rabbits leads to deficient growth of nasomegaly cortex, that is midface. Here in these patients, the injuries occur in this region, nasal septal region, so it failed to develop and leading to class 3 malady. And this rabbit, when the nasal septum was removed, then there is a deficient growth of the upper region. Next, functional matrix theory given by Melvin Morse. It is most widely accepted growth theory. And it was based on the relationship between the form and function. Means form is determined by the function. So it was developed complementary to the original concept of functional cranial component, which was given by the Van Clough. He stressed the dominance of non-osseous structures of the craniofacial complex over the skeletal component. Means non-osseous structures, it determines the growth of skeletal component. So the totality of all soft tissues, organs, and functional space associated with single function is taken as a whole, as a comprising the functional matrix. And the corresponding skeletal tissue which supports and protects these related specific functional matrix, they comprise the skeletal. Like functional matrix of masseter and medial pterygoid, which is functional matrix, which helps in the mastication. And its corresponding skeletal unit is ramus and some parts of body. So these are the skeletal units. According to functional matrix hypothesis, origin, form, position, growth, and maintenance of all skeletal tissues and organs is always secondary, compensatory, and mechanically obligatory necessary response to the chronologically and morphologically prior events or process that occur in specifically related non-skeletal tissue. The organs are functional species. So in this view, the soft tissue grow and both bone and cartilage react to this growth of soft tissue and they are grown in response to soft tissue. So Maas stated that the bones do not grow, but bones are grown in response to soft tissue. The functional cranial components, all tissues, organs, spaces, and skeletal parts necessary to carry out a given single function is called the functional cranial component. For example, head is a composite structure and number of relatively independent functions are operated in the craniofacial region. So these include like respiration, olfaction, vision, hearing, balance, chewing, digestion, swelling, speech, and neural interdigitation. So these are flowcharts of functional matrix theory. The functional cranial component, it comprises functional matrices and skeletal unit. Functional matrices include a periosteal matrices, which comprise blood vessels, nerves, and muscles, and capsular matrices, which comprise of organs, functional spaces. And the skeletal units divided into macroskeletal unit and microskeletal unit. Macroskeletal unit like mandible, maxilla, cranium. Microskeletal unit like condyle, conoid process, parietal, and temporal bones. And functional cranial components again divided into the functional matrices, which is soft tissue component and skeletal unit. So functional matrix include all the organ, tissue, and functional spaces taken as a whole. Whereas skeletal units, all skeletal tissues is related to specific functional matrix. So in skeletal units, all the skeletal tissue related to specific functional matrix. It may be comprised of bone, sutures, cartilage, synchondrosis, and tendinous tissue. So skeletal tissue is made up of several small contiguous skeletal units. They are called as microskeletal units. And when an adjoining portion of a number of microskeletal units work in tandem to carry out a single cranial component, then it is called a macroskeletal unit. Like these are microskeletal unit of mandible, condyle process, conoid process, alveolar process, chin unit, body, and angular process. So these are the microskeletal unit of mandible. For maxilla, orbital bone, body, pneumatic bone, alveolar bone, and nasal bone. These are the microskeletal unit of maxilla. So these are microskeletal unit and macroskeletal unit. Mandible have microskeletal unit, condyle process, conoid process, angular process, alveolar process, and corpus or chin. Maxilla, orbital, maxilla, pneumatic, palatal, and basal bone. There is cranium, parietal bone, temporal bone, frontal bone, occipital bone, and synchondrosis. So the functional matrix, which is soft tissue components, all the soft tissues and spaces, including muscles, glands, nerves, blood vessels, fats, teeth, and functioning spaces that perform a given function. So it is divided into two types: periosteal matrix and capsular matrix. The periosteal matrix corresponds to the immediate local environment. They are muscles, teeth, blood vessels, nerve, and glands. So these matrices act directly and actively on the adjacent skeletal unit. And with the direct action, skeletal tissue undergo transformatory changes. And with the direct action, skeletal tissue undergo transformatory changes by the deposition and resorption process. So net effect is to alter the form of the particular skeletal unit. The capsular matrix include organ spaces that occupy a broader anatomical complex, acts indirectly. In peristalmatics, they act indirectly, directly, whereas in this acts indirectly and passively on their related skeletal unit, producing a secondary translation in space. Whereas in peristalmatics, there was transformative changing. So these alteration in space is brought about by the expansion of the orofacial capsule, within which the facial bones arise, grow, and are maintained. And no deposition and resorption occurs in this capsular matrix, whereas deposition and resorption occurs in periosteal matrix. For example, neurocranial capsule and orofacial capsule. So each capsular matrix is an envelope which contains a series of functional cranial components, which is skeletal unit and related functional matrix, which as a whole are sandwiched in between the two covering layers. These are the functional matrices operating on this skull. These are expanding eye, expanding brain, sphenosphincter syncondylosis cartilage growth, enlarging tongue, growth of nasal septal part. Neurocranial capsule. So it comprises brain and covering layers, epineuritis, dura mater, skin. For this, skin and dura mater form the covering. The skin from the outside and dura mater from the inside. And orofacial complex, the capsule. So this is a neurocranial capsule, and this is a orofacial capsule. So orofacial capsule comprises of space like oropharynx, nasopharynx, which arise within the facial bones, grow and are maintained. And for the facial capsules, the skin and mucosa form the covering layer. Skin from the outer side and mucosa from the inner side. These are the microskeletal units, capsular matrix, periosteal matrix, and microskeletal for the brain. So macroskeletal unit, the neurocranium enlarges as a result of growing capsular matrix, that is brain, with a secondary growth at the, these are the sutures and syncondyles. While the capsular matrix, primary growth of the capsular matrix, that is brain, results in simultaneous or secondary growth of the sutures and syncondyles. Periosteal matrix, the functions of muscles which are attached here, the pull of the microskeletal units and leading to growth. Whereas microskeletal units, the neurocranium is composed of a number of neighboring bones which are individually the microskeletal unit. Von Limburg's multifactorial theory, it is a synthesis of positive aspects of the three basic theories: Scott's convergence theory, Seeker's sutural dominance theory, and Morse functional matrix. The positive things were taken and the drawbacks of the above theory was left out. Okay. The controlling factors in craniofacial growth includes intrinsic genetic factors, local epigenetic factors, general epigenetic factors, local environmental factors, and general environmental factors. These are the controlling factors in the craniofacial growth according to von Limburg. So controlling factors in craniofacial growth, the intrinsic genetic factors, they are genetic factors inherent to the skull tissue. While local epigenetic factors, that is capsular functional matrix, genetically determined influence originating from the adjacent structure and spaces like brain, eye, etc. Whereas general epigenetic factors, it is genetically determined and influence the originating from distant structure like sex hormones and growth hormones. Whereas in local environmental factors, that is periosteal functional matrix. So local non-genetic factor influences originating from the external environment, like habits, muscle force, etc. Right? General environmental factors, the general non-genetic influence originating from the external environment, like nutrition and oxygen. So these are the various factors: craniofacial, cranial differentiation, chondrocranial growth, desmocranial. For the cranial differentiation, the intrinsic genetic factors, local epigenetic factors, and general environmental factors play a role. For the chondrocranial growth, The intrinsic genetic factors, general epigenetic factors, and general environmental factors play a role. For the desmocranial growth, intrinsic genetic factors, local epigenetic factors, local environmental factors, and general environmental factors play a role. Next is in-lodge V principles of growth. It is also called an area relocation. It is most of the facial bones have the V-shaped configuration. Like here, it is a V-shape. So bone deposition occurs from the inner side here of the V and resorption from the outer side of the V. Here, positive sign means bone deposition and negative sign means bone resorption. And due to this, the bone moves in the direction of towards the wide of V. And also the bone deposition occurs at the ends of the both arms of the V. So simultaneously, deposition takes place at the ends of the two arms of the V, resulting in its binding. So these growth shift and changes involve corresponding and sequential remodeling of adjustment in order to maintain the same shape of that particular. It occurs in a base of mandibular body, coronoid process, condylar process, and palate. Like here, these are the body. It shows the V-shaped configuration. Here, as this is as a bone deposition occurs from the inner side and outer side, and at the end of the V, it grows and becomes wide. Like growth of the coronoid process. These are face. It also the sutures they are arranged in V-shaped configuration. So the face growing downward and in forward direction. Here the palate, we can note the palate increase in width as well as a dip follow the in-law width principle. This bone deposition occurs at the inner side and resorption from the outer side. And bone deposition occurs at the both ends of V. So in-law counterpart principles. Growth in any one region of the skull necessarily influences growth in others. Consequently, a functional equilibrium is maintained. So growth of certain skeletal parts of the craniofacial region, they are related specifically to other structures and geometric counterparts in the face of the cranium. So these various components of the craniofacial structure, they grow simultaneously. So thus, the counterpart principle suggests that the imbalance in the regional relationships are produced due to variation in magnitude of growth between the counterparts, timing of growth between the counterparts, and direction of growth between the counterparts. These are the various counterparts in the craniofacial region: mesomegaly complex versus anterior cranial fossa, medial cranial fossa versus width of the ramus. Here, this is a mesomegaly complex, anterior cranial fossa, medial cranial fossa, width of ramus, maxillary arch, mandibular arch, body of the maxilla, corpus of the maxilla, and this is maxillary tuberosity versus lingual tuberosity. So here this is anterior translation. Length of the anterior cranial base A is a growth equivalent to growth of the mesomegaly complex, that is C. Here lengthening of the spheno-occipital syncondosis M region is growth equivalent to pharyngeal region P, and the anterior-posterior lengthening of the ramus. So also note that this lengthening of the ramus of mandible is to accommodate the growth of the mesomegaly complex, and hence both are grow equally. Also note that just like mesomegaly complex, most of the ramal growth occurs posteriorly, but the mandible it displays in anterior direction. Here in vertical direction, the combined vertical growth of the clivus of spinal bone and ramus matches the composite vertical growth at the mesomegaly complex here and the alveolar bone. And note that the most of the ramal growth here occurs in cephalodirection, but the mandible displays in caudal direction. Here growth occurs because growth occurs at the head of the condyle and displaces the mandible in down. Next, neurotrophism. This theory states that the nerve impulse involving exoplasmic transport has direct growth potential. It also has an indirect effect on the osteogenetic growth by the influencing soft tissue growth. So different types of neurotrophism mechanism are neuroepithelial trophism, neurovisceral trophism, and neurotrophism. Next theory, most popular theory, servo system theory. So this theory states that the craniofacial growth happened because of growth signals and feedback mechanism. So Petrovic theorized a cybernetic model for the servo system. It states that the occlusion provides a constantly changing input. Means changing occlusion give a input signal, which influence the horizontally regulated growth of the midface and also the anterior cranial base. This mid-phase growth then serves as a rate limiting factor of growth of mandible. Means growth of the mid phase is the rate limiting factor, whereas occlusion provides the changing in occlusion, it provides the input for the growth of the mid face and craniofacial anterior cranial base. So according to this, the growth of the primary cartilage, which is maxilla, it is controlled by the somatomedin hormones complex through a cybernetic form. And there are no local feedback loop for the growth of the maxilla, which are the primary cartilage. Whereas the growth of the secondary cartilage occurs on the head of the condyle by somatomedin hormone. So this complex is by direct or indirect effect on the cell multiplication, not by the command. Means growth of the maxilla is occur by command method, whereas growth of the mandible by the feedback mechanism by the direct and indirect effects of the multiplication. So the indirect effect is by the influence of local factors multiplication. With condylar, coronoid, and angular cartilage, these indirect effects correspond to regional and local factors involving primarily neuromuscular mechanism related to the postural adjustment. These are the summary of servo system theory. Means here the release of hormone like somatomedin hormones. These are the command. So these hormones they affect the growth of the control the growth of the maxilla, which act as a reference input. So when the maxilla grow forward, then there occurs a change in occlusion. Means there is disturbances in the occlusion. Here means the growth of the maxilla is reference input and change in the occlusion is output. Maxilla grow forward and downward. It affects the occlusion, changing occlusion. So this output changing occlusion. Okay. So there occurs, it affects the TMJ. Means occlusal deviation, it was detected by the TMJ, and this occlusion deviation, so change in occlusion causes deviation in occlusion. So a signal goes to the central nervous system. Means it said that there is occurs disturbances in the occlusion. And here from here, the proprioceptors and periodontium and TMJ. From here, the signals occurs to these area and they control the growth of the mandible. So change in the occlusion pursued by the CNS system, central nervous system, and from here it gives the signal to growth to occur the growth of the mandible. And then again normal occlusion achieved And again, the growth of the maxilla causes the deviation in occlusion, and these cycles go, and so the growth of the maxilla, it follows the growth of the followed by the growth of the maxilla. And also the change in occlusion by the local feedback loop, it causes the growth of the maxilla. So here you can see there is a local feedback loop in the case of the maxilla, and whereas in the case of maxilla there is no feedback loop. Thank you.